Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk with Dr. Kevin Simon about an article that addresses the issue of involuntary police transport of individuals being taken to the hospital for evaluation. It's very disturbing, compelling, and important.
So we're very happy to have Dr. Kevin Simon, who is the Chief Behavioral Health Officer for the City of Boston, here to talk with us about his and co-authors' article, Understanding Involuntary Hospitalization, Application Submitted to an Urban Police Department. So Dr. Simon, thanks so much for joining us.
Yeah, it's a pleasure to be here.
Just to start us off, tell us a little bit about your career path and what you're doing now and how they kind of led to this particular paper and topic area.
Yeah. So again, thanks for having me on the air. In terms of career path, as you noted, I'm the Chief Behavioral Health Officer for the City of Boston, and I got appointed to that role back in 2022. By clinical training, I'm a child psychiatrist, adult psychiatrist, and addiction medicine doc. So I still maintain some clinical privileges in the Boston area at Boston Children's Hospital. In terms of how did I end up here, even during residency, I've always had the idea of wanting to be involved in public policy, mental health care reform. And after clinical fellowships, I was in a leadership fellowship called the Commonwealth Fund Fellow. And there, it's been in existence greater than 20 years, and there are a number of alumni who are involved in local, federal, on the payer side, leadership. And it happened to be the right time, right place that the city, along with many municipalities, secured, ARPA funding or American Rescue Plan Act funds in response to COVID. And at the time, the city, like many cities, has a public health department, but did not have someone necessarily charged with thinking about and executing like a citywide plan as it pertains to mental health and behavioral health. And so while the Boston Public Health Commission, or BPHC, has many bureaus, and we are responsible for 2 shelters, we're responsible for an engagement center where individuals that might have substance use challenges, go for services, and EMS, where we are responsible for. There wasn't a person and team thinking strategically about behavioral health. And so the commissioner, Dr. Ojikutu, and the mayor, Michelle Wu, recognized that it potentially would be beneficial to the city to think about it. And so I was recruited, and through the support of mentors, advisors, and recognizing wanting to have an impact other than just impact by where is it that we publish, right, in academic medicine, thought that being in community is where I feel kind of like most myself. And so that's how I am in the role that I'm in.
So you've been doing it for 2 years, and I'm asking because it does seem like somewhat of a unique role. I mean, I think that, a lot of cities have somebody who's within the health department and is the behavioral health person there, but your role seems even a little bit more, I'm not sure, all encompassing. So I'm just wondering how it's been to be at that perch and how you found the job or even crafted it, since you're the first one.
Yeah. So from a clinical standpoint, I kind of consider myself like a liaison within the city, in that regularly communicate with our school district, our police department. In part, to operate a city, there are many different sectors that are involved with each other. And again, many are engaging in mental health services, behavioral health services, sometimes whether they recognize it or not. And so in terms of being in the role, the first kind of operation that was important was we had this funding that we needed to ensure was allocated. I have to say last year, because in 2024, after a year of planning, we were successful in initiating and distributing $21 million as it pertains to behavioral health activities across the city. The predominant resources being allocated around school behavioral health improving pathway for people that are from the Boston area, BIPOC, to pursue careers in behavioral health, because we all recognize that there's a shortage. And then also funding efforts in local kind of K to 12 schools. And then also upskilling, because we'd often hear from constituents, staff that are not clinicians. I had young people and old people coming to me revealing things that I not fully equipped to necessarily manage. And so now we have a kind of training institute where if you are, the local water department, if for some reason they want training, they can identify a subset of people that will then be kind of like the champions of the local department. And then a lot of these things came from our community health needs assessment. And so, surveying thousands of people, one of the messages we regularly heard was, we don't know what's available. And, if you're not a major and, kind of for-profit entity that can put commercials out very regularly, it's like, oh, wait a minute, let's use some of our funds for a public mental health campaign. And so we just completed that. It's called Heads Up. In part, we wanted to make sure that people knew what services actually are available kind of across the city. So in terms of the being in the role for 2 years, I like thinking about social determinants of mental health. And this role affords that, because I talked to a housing colleague and we created an RFP for credible messengers, which I'm sure you all know. And it's like, well, would the credible messenger be best if it was done through, a community behavioral health center? Or actually, oh, what about if we did it at a housing complex? Because there's a good chance that there are credible messengers at the housing complex. And so that RFP came out from our Boston Housing Authority, not from the Boston Public Health Commission, but they certainly collaborate with us on what to do. So having that public policy, mental health, social determinants frame of reference, I'm able to be helpful to many different departments across the city.
It's very impressive that, you've been able to both be generative and be sort of, creative, generative, and sort of make all these things happen. I'm just sort of sitting here going, wow,
Appreciate the comment. I think this is certainly not like Kevin unto himself. There's a team, our local public health leadership, the mayoral leadership, being truly intentional about wanting to bring people to the table is imperative. And, in terms of the leadership that we have across the city, if it's me in my role and someone has called our 311 system and they send me a message, hey, Dr. Simon, there's some issue. I actually want to really resolve the issue. And the team recognizes he's not asking us to do anything that he himself wouldn't do. And so I think there's certainly a cultural shift and change that seems palpable to others. But yeah, really, I think the clinical training that I received, the public health training, and I think just being a psychiatrist, we tend to want to understand not just the symptoms that are coming and the person's presenting, but that factor must be, tell me about your family, or tell me about work, or tell me about some other aspect. But often in clinical work, we can ask and may not necessarily have some tool to actually impact that other element or domain of that person's life. In this realm, I'm certainly not creating housing policy, but certainly can think about, well, how can we have mental health be a part of the discussion, even in housing or in the school, transportation, it comes up.
I mean, it's a fascinating role. It's like your clinical training, it's policy, it's like social determinants work, and it's this, I think you mentioned, kind of like a systems consult liaison role as well. So it's a really unique like viewpoint that you have. And so I'm really happy you're here to share some of that with us here today. And in terms of this collaboration, who are your co-collaborators and how did those particular ones develop?
Yeah. So my co-authors, there are a couple of graduate students, but then there are senior scientists and faculty. So Jenna Savage, she's within the Office of Research and Development at the Boston Police Department. And then Melissa Morabito, she's on faculty at UMass Lowell, a professor of criminology. And Jenna and I came across paths in part in me just trying to understand all of the different departments. And I'm having meetings with the police department. I'm like, oh, wait, there's an Office of Research? And Jenna and I spark up a conversation, recognizing that we're actually really vested in understanding the nuances and slowing down. And so, interesting enough, within our state, we have a Department of Mental Health. And because of the role I'm in, I got alerted to a concern that one of the medical directors for one of the houses that DMH clients are in, that the police were asked to come to escort somebody to the hospital. And I was actually being alerted that the police did not, quote unquote, escort the person to the hospital. And my clinical colleague was very frustrated by that. And so I said, hey, I don't have jurisdiction over what the police do, but I'll certainly look into it. And in the summer of what I say, the summer of Floyd, 2020, post George Floyd, Breonna Taylor, and the kind of racial reckoning that the country was in, there was a recognition by police leadership, of which by that time actually had not had any egregious acts happen, but said, we certainly want to engage our citizens, constituents differently. And by differently, they said, well, what can we do better? And one of those things tends to be this mental health evaluation or transport to the hospital for mental health evaluation. And what they did was they increased the amount of crisis intervention training or CIT, that hours that they have. And then they formed a specialized unit that when these orders come in, this particular unit that even has more training is going to be the one that goes out and makes their own actual assessment. At the time, apparently the assessment was they went to the residents, asked the individual if there was a concern, then the person fully knowing how to utilize the system said, no, if I have an issue, I know how to call 911, I know how to get to the hospital. And they said, no, this person doesn't seem to actually meet criteria for Section 12A, is that what we call it? And that then made me say, oh, wait a minute, there's been a shift. You all were doing things one way pre-2020, now you're doing something different. Like, that's a study. So I was like, can we look at the Section 12 applications that have been submitted from June of 21 to July 22, and let's just characterize who sections are being written on and what information is gleaned from the applications.
Just to give folks some context, like when you do this beautifully in the paper, could you talk just like what is Section 12? Like, how does it work? What is it? What is the context of these police involvement in these involuntary transports?
Yeah, so Section 12A, or involuntary transport to the hospital for mental health evaluation, is a process that exists in Massachusetts as well as most of the other states in our country, where if somebody is deemed to be experiencing a mental health crisis that is organic in nature also, that certain people can make that assessment and sign this petition or order to have that person transported to a hospital emergency room and get evaluated. In Massachusetts, on the form, you come to realize that there's actually 5 professions that can fill out a section: a licensed physician, a licensed psychologist, a licensed clinical social worker, a licensed nurse, and a police officer. Now, of those 5 professions, only one is actually legally allowed to take some person against their will, which is the police officer. Which is why even when a person calls 911, if the person said, I don't want to get on the gurney, 911 or EMS does not have the jurisdiction to say, no, you must. And so a lot of times police officers show up with the ambulance in the event that they really do need to go, even against their will. And so an interesting facet here is many providers are aware of the section order, but then sometimes, myself included, we don't always think about the full mechanism by wait a minute. If I wrote this section, the person's not actually coming in my car, and they're often not going in the clinician's car. You are actually necessitating some legal involvement. And so, we can talk about alternative response models, but as it currently stands, when in Massachusetts, when you file a Section 12A, you are actually necessitating that police officers show up because they're the only one that actually have the legal jurisdiction to take someone involuntarily. And I'm not sure how often the person who's writing the order is communicating to the individual, hey, I'm writing this order on you and I'm calling the police. So sometimes I think constituents feel I was experiencing this distress and then the police showed up. What the heck happened? That communication of, oh, actually this process necessitates that they're involved. I think that's another thing that we're trying to convey through the paper, that there's a lot more that we can do across the field in improving what this process looks like.
I would just say that I really can relate to that because there's so many complex parts of that process that you've described, but that you don't really think about as a clinician. So it's like, oh yeah, there is a transportation issue here.
Mm-hmm.
And I have to say, just being aware of it is probably important. I mean, there's help making it work better and more fairly, but it just feels to me like some of this is just so invisible at times.
Right. No, you're correct. Because we learned this in vivo, you end up practicing it the same way that you learned it. And there are many times that I've been in the hospital and someone's like, wait, who fills out the section? It's like, oh, you don't, maybe you do, but you haven't looked at it to recognize, wait, who are the people that can actually fill this out? And then what does that mean that I filled it out? So that's what this paper and our evaluation was trying to characterize.
When we've talked about papers around involuntary commitment in the past, I'm just always surprised about not so much what we know, but how much we don't know about like the details around, both in terms of like what happens generally sort of across the country, but even within municipalities or smaller kind of geographic areas, about just even basic information about like who's filling out the form, like how often are people getting transported. So maybe by way of like getting into some of the details of the paper, you could tell us a little bit about what we or you knew about involuntary commitment in Boston prior, what questions you had, and then how you went about answering them in the study.
Yeah, so certainly knew that there likely I suspected that there were likely disparities and inequities in reference to the process. Knowing the data about involuntary transport to be evaluated, as well as involuntary and hospitalization in a psychiatric unit, there is a disproportionate rate of individuals that identify as BIPOC, Black, Indigenous, people of color, experiencing those outcomes.
You also mentioned that there's an actual form that people are filling out, which seems like it was probably a very rich source of data for you. So what did the form, like what other things does the form collect, and how did you use that when you were trying to analyze what was actually happening?
So the form collects the identified patient's information. While there is the race, because the person who's filling it out is not oftentimes the person that is going to be transported. The race is actually subjective on the person filling it out. So we recognize that nuance is important because maybe somebody, phenotypically looks a certain way. And so then I say, oh, this person is Asian, yet entirely they may not actually be. It just might be my own bias of what I think an Asian person looks like. Also on the form, it does specify, is this a psychiatric? And they put broad generalizations of, bipolar, psychosis, diagnoses there. Also, is this actually not primary psychiatric from a condition standpoint, but is there a threat of HI or homicidal ideation? Also, it notes that much like many of our DSM criteria, it says cannot be due to substance use. And then it asks the person who's filling it out what your credentials are, and then where is it that you're trying to transport the person. And so that's the 12A. And then on the backside, we didn't fully go into this in the study. The backside is you've had the evaluation, and the 12B is usually for the person that's being admitted, and the admitting physician says, yes, I accept this person to our unit involuntarily. And so I think over the year timeline that we looked, it was more than 450 that we were able to assess, a little bit less than 500. But the findings themselves, again, helped us think, wait a minute, there's more here. And so, for instance, in real time right now in Massachusetts, and I know in other states and cities, we have alternative response model or co-response model. And so, another iteration of a study that we want to do is, what does it look like when the section is ordered and all sections get sent to the Boston Police, at least in Greater Boston Police Department? What does it look like for the co-response team to actually go, even separately and different than the current street outreach team that does have a little bit more mental health training, but this co-response would actually have a clinician, and trying to see what that looks like. The other thing that we want to look at is how many of the involuntary transport orders actually result in an admission, right? Because I could be the clinician in the community, I send the person, and what percentage of those emergency room admissions result in a 24-hour observation? Person, maybe they sober up, that they deem that they're just, not actually suicidal, and then result in a discharge. There's a suspicion that there's actually a high percentage that do not convert into an admission, yet that is an expense because, again, hospital transportation, the EMS thing in Boston, it's around $1,500. And if we're talking about a population that has serious mental illness, for instance, oftentimes maybe they're on Medicaid, or we call it mass health, but maybe they're not. Well, then the $1,500, some municipality has to pay for it.
So another one of your findings when you looked at these 500 odd section petitions were that 70% of them resulted in an involuntary transport to a hospital for evaluation. Did you have a sense of what's happening between those 70% and the 30% that don't result in a transport?
Yeah. So good question. In terms of the 30% that don't result in the transport, strong suspicion here is the team went out, the police department team went out, could not find the person, right? Because again, the section that is being written, sometimes it's being written from a clinician that, yes, maybe has the individual in their office, but it could have been that the request for the section or the petition for it might have been written by someone that was at a housing facility. And oftentimes we may not know, well, where did the person go? So I think that's what's happening in that, well, at least a percentage, that 30% that are not completed, is they did go out and we don't even know where the person is.
Once the section petition is completed and the police go out, if they do find the person, are they obligated to do the transport, or do they have discretion if they find the person and they're, like you in the example you offered earlier? I'm fine.
Yeah. So this is the technically, by the letter of the law, in terms of the professions that can fill out the section, the police officer can show up, say, hey, we've done our own mutual assessment and we don't deem it necessary. However, from a professional courtesy standpoint and historical kind of precedent standpoint, someone submits the order, the police officers will say, this has been done, and we'll want someone at the hospital to justify that this person does not need to be admitted. And so, in shifting how, in the Boston Police Department, shifting how they want to actually better engage constituents that are experiencing a crisis, there's also trying to reshift the cultural dynamic of what this process is And just because the police department might recognize, hey, we want to engage people differently and do it better, more humane, ethically, the thousands of clinicians that are in the community may not recognize, oh, this is what they're doing. And so still, a lot of times when the orders are submitted, they will bring the person to the emergency room to be formally clinically evaluated. So this question here kind of hinting at like system change, right? And if you want to improve something, and we could all know it's meant to be improved, is everyone brought into the idea that this has to be improved? And are there professional nuances where people might feel, why are you changing my aspect of my role and my field, but you're not doing anything to your field? And so kind of recognize these dynamics in an interdisciplinary team where we have EMS colleagues that are like, oh, yeah, section, we're actually not even one of the 5 professions on the section, which is true. But they certainly are first responders. Psychiatrists, a lot of times when presenting about involuntary transport, first question is, are the police trained enough? And it's like, well, actually, they're pretty trained to engage people that are in distress of all sorts. But how often do we actually engage people in distress in the community? It's a different thing to say when you're on an inpatient unit or in the hospital and you can call on staff. But in part, one of the things on the form that you were asking me earlier, not characterizing why I'm filling out this order, I now think of it as like an egregious fault of ours, because you're then asking an officer, whether they have 100 hours of CIT training or not, hey, go pick up this person that I think is distressed enough to need a hospitalization. And by the way, figure out how to do that, just talking nicely to them. So I actually am more in recognition that we all have areas to improve. And in terms of one of your earlier questions was, how did we get engaged in thinking about this as a study? One of the challenges in being in this new role, and yes, I am a psychiatrist, there was a lot of like relationship building that was required with the idea that I want to look at police data and publish it. Like, who are you, Dr. Simon? And so there truly was, hey, let's just get coffee.
Mm-hmm.
Or the baseball game or the basketball game between the fire department and the police department. Hey, I'll join. I'll ride the bench. This is relationship building, and it's necessary because we come in and we want to make changes. But who are you to say that this thing has to be changed? What are you actually demonstrating to me as a person that respects my profession, that I want to be helpful? And so I said, oh, hey, I do not want to make this harder for you. I just want to make this easier for you. But that, a lot of relationship building.
I mean, there's so many like cross systems, ethical, equity, historical issues that are tied up in this process and this topic, and a lot of different lenses that people bring to this. Do you have a vision of how like this should work or could work better? Like, what, from your vantage point, like what do you see as, maybe we won't make you solve the whole thing, but even sort of as like a next step for improvement?
There are models across our country where this looks different. Before even referencing some of the models, I will say in each of those cities where these models do exist, where we would say there's been improvement, there are still constituents, advocacy groups that say, we want zero involvement of the police. And that contingency also exists in Massachusetts. In reference to models that have some evidence and seem to be working, there's Cahoots out in the West. Recently in the Midwest, in Detroit, they have a specialized mental health unit, a part of their police department, that when they go out, they do not have any firearm. They have a whole different color uniform, and they have had positive results of being able to bring people in, or even, again, verbally de-escalate individuals in the field. I think in Massachusetts or in Boston, we have multiple alternative response models. So we do have a co-response where a clinician and a police officer go out. We also have a co-response of a clinician and EMS go out. We also have tele-EMS, i.e., if the dispatcher asks a certain questions, come to realize that, oh, this is actually behavioral health, further inquires, okay, could this actually be virtually done? So I would say for as nuanced as individuals are, we do need to have multiple pathways to being to help people who are experiencing distress. Because oftentimes the moment or the episode of distress is an episode. And how do we connect the person that's in the episode to the right types of, longitudinal outpatient services if they don't have those services? And so there is no like one solution. And I think I fully understand advocates that say they don't want any police involved. Yet I also fully recognize sometimes just by the necessity of suggesting that we have to bring a person against their will. And so one could argue ethically, well, is there a space where taking people against their will doesn't exist, right? And again, that's like a theory question. But right now, in many of our states, somebody might be experiencing distress and people recognize this person needs help. They then say, why did you let me exist that way in the street? So this is a very complicated area. And that's why I think in terms of solutions, there has to be just many pathways and opportunities to treat people right, even when they may not recognize it for themselves.
So I think that's a good place to wrap up. And we just wanted to thank you for the paper and for joining us today and all the really interesting work that you're doing in Boston. And we're looking forward to hearing more on this topic and others from you in the future.
Yeah, no, thank you for sharing this platform for us to talk about it. Really appreciate it.
And I concur. And I think the really careful, almost microscopic components, of this whole process are so important because this is what people experience. And so you're sort of taking it apart and sharing it and critiquing it and coming up with alternatives is really important and valuable.
Oh, thank you.
That's it for today. Thanks to Aaron Van Doorn for mixing and editing and Demery Jackson for additional production support. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.